Good morning. How are you this morning? I'm George Johnson, and I'm happy to be here with you. We have a special event today. The parking lot is full, so we got some long walkers still to arrive. Well, let's start it off. We're going to have a special speaker, and this concludes our annual program. We're not going to be meeting next month, so you'll have some time off for Thanksgiving and Christmas and celebration. I'm going to be celebrating before we start for our January 20th meeting, and I'm going to be celebrating 85 years of my birthday. And thank you. And more importantly, celebrating 20 years with prostate cancer. And more importantly, 10 years since I had recurrence after radiation treatment. And I came into these rooms, and I sat over there. And I followed some good friends and some good doctors' advice, and I've had this now with a Gleason. I came in here with a Gleason 8, with a doubling time of 3 months. And I'm still standing tall and enjoying life. So for you newcomers, you got lots of time. Take it easy and follow our program on case management, and you'll do very well. And so I got a lot to be thankful for. Particularly, we need to be thankful for our friends here that provide these wonderful facilities. The Sanford Burnham Previs Medical Discovery Institute. You're going to be discovering some things today, hopefully, that you can apply in your program. If you need some more facilities, we have them down the back hall, and it's quite an exercise walk to get there, but hang in there. It's down there. Here are the guys that make this program work. These are our volunteers. We have 9 volunteers who are dedicated to serving your interests. We got room for one more in case somebody wants to volunteer. We could use some of that. Okay, the newcomer package. Did every newcomer get a package?
Yellow sheet?
Okay, the important thing is the yellow sheet. You fill that out, and you'll get a call from my buddy Gene in case you got any questions about our program and the services we can provide you. And welcome. Our support group, what's our purpose? We're a patient-focused group that shares experiences to become your own case manager. You have to manage your own case. The doctor will not do that for you. He has thousands of patients. You're the one that has to keep a record of your tests and your appointment schedule, your questions you want to ask the doctor, and bring a notebook when you see him so you can ask the questions and write down the answers. We are not a substitute for your medical professional. You have your own doctor. Hopefully what you'll benefit from the meeting today is some questions you may want to ask your doctor. What about this and how come that? But we're not a substitute, nor is our guest speaker a substitute for the medical profession. Okay, for us to be able to support you, here's what we got. And we've got a website. There's the website URL. And we have a library. Look at this. Look at this. We've got Big Bill Bailey. He gets his exercise hauling all those books and DVDs. Some are for rent and some are for sale. If you buy it, we make a couple of bucks off it, which we're always looking forward to having additional funds. And the newsletter, we have, where's Steve? Steve is our editor. There he is back there. Steve Prendergast is the guy that works hard on it, particularly trying to find a few humorous pictures and stories in there too, besides the research results. We have an outreach for new members. I want you to, here's our newsletter. And what happened to the lights? Okay. I don't know that we need them.
Your eyes going bad?
Oh, these went out. There we go. I may have I may have touched it. I won't go there again. Here's the brochure for an outreach program. Grab some of these brochures and take them to see your peer group, your fellow buddies, because if you got prostate cancer and if you got 6 buddies, at least one of them is going to have prostate cancer too. And also, if you're older like me, you have sons, and because you have it, you need to tell your sons when they're getting to be particularly 40 or 50 to go get a PSA. That's very important. Monthly meetings. Here's what's coming up. We won't see you next month, but in January we got advances in radiation therapy from a good friend of this program, A.J. Munt, who's a professor and chair at UCSD. And he will be updating you on what's new in that kind of treatment program. Okay, I'd like to get your participation. Please raise your hand in response to how many are here for the first time. Look at that. Okay, your friends in the seats, look around, welcome them. I'm sure you'll want to come back after you hear this our talk today. How many have been recently diagnosed in the last 6 months with prostate cancer? Well, we're here to encourage you to be your case manager, and hopefully you'll become informed. How many have had prostate cancer for up to 1 year? Okay. Now, we're doing this for the newcomers and for Dr. Lamb to see how this program has modified and changed in the next couple of slides here. How many have had prostate cancer up to 4 years? Raise your hand, please. Okay. 5 to 10 years. Look at those hands. Isn't that wonderful? It's working. It's working. 11 to 15 years. See there? Okay, good news. And anybody higher? I got 20. Anyone can beat me? How many years? 15. Okay, back there? 19. Okay, I'm going to wait for you. I'm waiting for you. Okay. Anybody higher than 19? All right, it's your turn. How many? 27. That's Jack. 27. Isn't that wonderful? Now look at that smile. All right.
Was he 14 when he got it?
Okay, an important measure is your Gleason Score. If you don't know your Gleason Score, you don't know what's going on, because that's the key to determine what treatment. So I'm going to ask you to raise your hand. How many have low-risk Gleason 6 or less? Raise your hand, please. There you go. You're candidates for active surveillance. How many have a 7, intermediate risk, a low 7, 3 plus 4? Raise your hand, please. Okay, quite a few. How many have a high 7, 4 plus 3? Looks like we got a few more in that regime. Okay, let's go to 8, 4 plus 4. How many have 8? Okay. How many have a 9? I'm a 9. Okay, see how we got advanced programs here for you. How many have a 10? There's a 10. Anybody else? Okay. Now, let's go now into the treatment. Because now that you know your Gleason number, you're going to have a better edge on what kind of treatment you should have. Okay. How many are on active surveillance and not had treatment yet? Active surveillance. So that's growing over the years. And that's good news. How many have had prostate cancer surgery of all kinds? Now that was the gold standard. Now we're going to move into radiation. How many have had radiation? See, we're getting more radiation now. Isn't that interesting? Yeah. And how many are on ADT of all kinds? ADT, yeah, a lot of us are on ADT. And we're going to be hearing about that too. Okay, chemotherapy. How many are on chemotherapy? 1, 2, 3, 4, 5. 5. Okay. New treatments. How many are on Zytiga, Xtandi, Zyfigo? We're getting more under the new treatments. Okay. How many have had recurrence? Yes. See, that's a growing number now. How many are undecided what to do next? Hopefully you'll figure out something to do next as a result of today's meeting. Okay, we're going to need your support. This is where I ask for money. Let's pass the baskets. We are a 501c3. We're tax exempt. And so dig deep. We got small baskets, so we need big bills. A big bill has a 0 on it. That's not on the serial number, but up in the corner. To break even, we need at least a 1 0 and so forth. And a 2 and a 0 is even better. But give what you can, and because this is our last chance to donate for this year. All right. Here's our 6 steps for managing your program. 1, early detection. The task force has kind of modified itself, but be sure you get your PSA done. Encourage your buddies to get it. It's very important. If you don't like early detection, you can have too late detection just by waiting. And don't be sure and get your PSA test at the doctor's frequency, at least once a year. I waited 2 years before I had my second one. After I was assured that my PSA was low, it was 0.7. I waited 2 years. Ended up to be 14.7. If I'd waited another year, it would have been 240. If I had waited another year, 2 years, it would have been 4,000. Yeah, my doubling time is 3 months. That shows you what the doubling, the growth of cancer can be. So that's why you need to get frequent PSAs. High definition diagnostic to find out where that tumor is, what places it is. We had a wonderful speaker last month, Dr. Almeida. We got a DVD. If you're interested in it, we'll mail it to you. Contact Gene. He'll take your money and we'll mail you the DVD. Or if you can wait till January, we'll have it here for you. Now, if you got high definition diagnostics, you can do targeted biopsies. The NCI just issued a report, National Cancer Institute, and this is a survey of prostate cancer specialists. 83.6% of the respondents, the experts, believe MRI targeted biopsies to be moderately to extremely beneficial in the evaluation of prostate cancer. That's a nationwide test. That is not true for San Diego. For some reason, MRI targeted or any kind of targeted biopsy is not prevalent in this area. What we have here is that urologists tend to want to use their old ultrasound to do the random, or what they call systematic study. 12 cores going in at random. That's not going to do it for you. And we highly recommend getting a targeted biopsy. Want to now introduce our guest speaker. How many have been up to Marina del Rey to see Lamb and the associates and Schultz and Turner? Look at that, huh? This is an alumni group, huh? Yeah. You have a lot of friends here. You're my friend too. And yeah. Now there's something special about this group. And what's special about it? Well, when you got a PSA, probably from your primary care doctor, and you had what he would consider a PSA that's kind of high, what does he do? He wants you to get a biopsy, and he sends you to a urologist. Okay? A urologist is a surgeon. He was very proud of his studies and his efforts and so forth. So he has a tendency to want to do surgery on you because he knows it works as far as he's concerned, and it's very appropriate. Prostate cancer for the average urologist is only about 20% of their practices. That's why you see women in the waiting room and so forth. It's for urology and not just prostate cancer. And so what we have with this group up here is prostate oncology specialists. They specialize in prostate cancer, not in urology, prostate cancer. So let me tell you about Dr. Lamb. He's a local LA guy. He got his bachelor's in biology at UCLA. He got a magna cum laude. That's not the football fight song. Then he went on to get his medical degree in medicine at, guess where, UCLA. And then he got his specialization in oncology. And first, he got internal medicine. That's what his focus was at the UCLA Medical Health Center. And then he got his specialty in oncology, fellowship at the Harbor UCLA Medical Center. So you can see the sequence of specialization that he has, and he's been focusing on prostate cancer for the last 18 years. So it's a real honor and a pleasure, and I know you are happy to see him, and so am I. Here he is. Yeah, this is the young Dr. Lanham.
I'm so full of testosterone, I grew this overnight in honor of November. Okay. So good morning, everyone. Good morning. So thanks for having me. It's another year has gone by, and so every year I try to cover some what's going on in terms of research and what's new in the prostate cancer world. So a little bit of background. Okay, you guys hear me better? Yeah.
First the...
Hello, testing? Testing. Okay, good. Perfect. Okay. So a little bit of background. Prostate cancer, as you guys know, is very common. It's the most common type of cancer, solid cancer in men, a second most common next to lung cancer. And it's, believe it or not, it's the second leading cause of cancer death in men, despite its fairly good reputation as a cancer that doesn't always kill people. Because of the sheer number of patients who are diagnosed a year, eventually there will be 10 to 15% of the men with prostate cancer will die. So every year we have about 26,000 men who unfortunately pass away from this disease, even though we diagnose up to 180, 190,000 per year. About 1 in 7 men will be diagnosed with prostate cancer in their lifetime. And currently, as of 2013, there were 2.8 million men in the U.S. living with prostate cancer. So 25 years ago, this was the field, kind of 50 shades of gray, like my outfit here. So every year that goes by, I've been doing this for about 17 years. We're beginning to, maybe we have 40 shades of gray now, instead of 50. But we're learning a lot more about this disease and are able to fine-tune and manage patients depending on their particular situation. So we'll try to talk a little bit about various aspects of this disease, including low-risk, intermediate, high-risk disease. We'll talk about relapse cancer, metastatic disease. We'll touch upon immunotherapy and radiopharmaceuticals towards the end of the talk. So low-risk disease is characterized by men with a PSA of less than 10, usually no nodules on their prostate exam, or a tiny nodule, what we call T2A, usually Gleason 3+3 disease. A small volume, Gleason 3+4 is also considered fairly low risk. Less than 25% of the cores involved on a random biopsy. So if the doctor did 12 biopsies, 3 or less cores involved with prostate cancer is considered low risk. Sometimes if you do a genetic profile of the cancer, they have favorable genetic pattern to it. It's not what the genes the patient has, but what the gene the cancer has. And if we do any imaging on ultrasound or MRI, you actually don't see the cancer. So not seeing a cancer doesn't mean it's not there. It just means that there's usually so little that you can't see it. So that would imply it's a low-risk, favorable cancer. So typically, for low-risk patients, active surveillance is becoming a very popular and established option for these cancers that tend to be very stable or grow very slowly over years. Of course, one may do curative therapy, and these are some of the curative therapy options, including radiation, seeds, surgery, cryosurgery, high-intensity focused ultrasound, HIFU. Well, you don't really need to do systemic treatments for low-risk cancer. Systemic treatment is any treatment that involves the whole body. So if you have a localized small cancer in the prostate, you don't need to do anything for systemically. I went over this slide, this study last year. Just kind of want to remind everyone about this PROTECT trial, where they randomized about 1,500 men to either surveillance, surgery, or radiation. Since we went over this last year, just want to emphasize a couple salient points. After 10 years, these low-risk patients, the death rate from prostate cancer is very low, only 8 on the surveillance group, 5 and 4 on the treatment groups. Another way of looking at it is even if you do treatment, there's a chance of dying from prostate cancer. But the likelihood, when you look at the actual percentages of surviving prostate cancer at the 10-year mark, is 99% for all 3 groups. Of course, when you're on surveillance, there is more progression. There's also more men with metastases, so that's the downside of surveillance, especially if you do it, if something bad happens. In men on surveillance, it's important to remember the big picture. We don't often die of prostate cancer. We die from other things, so look both ways when you cross the street. Get your heart checked, get your colon checked, get your vaccines, take care of your blood sugars, etc. This is a study that came out this year, a different group of men. This is patients that were randomized to not just surveillance, but just good old-fashioned watchful waiting, waiting for things to get worse, not actively monitoring super carefully. So this is called the PIVOT trial that started about 19 years ago. These men had a slightly higher PSA, a little bit older. They followed these men for 20 years, and half the group had surgery. The other half of the group were just monitored and just basically never had surgery. They just had some hormone therapy, chemotherapy when things got bad. And so they looked at both groups. Turned out that the group that was on watchful waiting, the overall mortality was about 67%. Even the surgery group, it was 61%. Again, more people die of other things. But they argued that although not statistically significant, probably if you did surgery or by extrapolation any treatment to the prostate, your survival overall is maybe a little bit better. So then you got balance. This is watchful waiting, not active surveillance. So there's maybe a little bit benefit in terms of intervention. So these are actually the numbers, though. They broke down the numbers here so to see if there's any particular group that if you did watchful waiting, it's a little bit more harmful, or in other words, which group should you consider treatment. So they compared the overall survival, or this is actually the death rate at 19 years of the 2 groups. So if you look at, if you were younger, if you had surgery versus no treatment, your death rate was about 12% less. Okay. If you had a higher PSA greater than 10, your death rate was 8% less. But if you're older and your PSA is less than 10, there was less of a difference or benefit to treatment, local treatment. Okay. Another way of looking at it is if you're intermediate risk, treatment was associated with an 8% improvement in outcomes, survival. If you're low risk, there's probably not a big difference in treating and no treating. The survival's about the same. If you're high risk, there may not be a difference with treatment because it's not that great survival anyway with high risk disease. So kind of looking at these numbers, you would think maybe younger, intermediate risk patients who have prostate cancer should have, they seem to benefit the most from treatment. Okay. So with that in mind, let's talk a little bit about these patients that will benefit most from treatment. These are the intermediate risk patients. These are the guys, as I alluded to earlier, have a Gleason score of 7. They may or may not have a nodule. Their PSAs are usually greater, but not too high, so less than 20. Usually when you do an imaging study, you finally do see something. You see a nodule or a lesion, medium, maybe large, but not breaking through the capsule, not invading into the seminal vesicle. And of course, there's no metastases. So these are patients who still have cancer within the prostate, but at slightly higher risk. And then on the genetic panel, they have a more of an intermediate type pattern. So these guys, you don't want to do surveillance. You do want to do treatment. And these are some of the treatments that you guys have heard about. You'll hear more about radiation with Dr. Munt next month, including seeds. You guys all know about prostatectomy. Cryosurgery is freezing of the prostate. And then you start needing to consider systemic treatment. Not chemo or anything too exotic or serious, but for intermediate patients, they might need a short to medium course of androgen deprivation. Why do treatment? Well, everyone's afraid of having some cancer in their body. We know that in some cases this cancer is deadly. Remember, active surveillance is a lot of work and it's a lot of stress, and you got to see doctors often, get MRIs, ultrasounds, biopsies. A lot of men, we like closure. We want to just get rid of it, thinking that we'll get rid of it. And it may or may not happen, but that's the only way to kind of get closure is to do something. Okay, and one way of getting closure and not having to deal with this is you get to avoid hormone therapy. So these are some of the side effects of hormone therapy, which some men have experienced, including hot flashes, tiredness, breast growth, osteoporosis, muscle loss, ED, depression, weight gain, insulin resistance, which is prediabetes, cholesterol goes up, a little bit of anemia, some memory impairment, not Alzheimer's though. Okay. So what about arguments against treatment? So, erectile dysfunction. You get treatment, you might not be able to turn it on. Okay. Or you might lose control of your urine with treatment. Okay. And then there's something that Dr. Munt will talk about. It's radiation damage. Okay. So. Who has this happen to them? No, I'm kidding. So this is what radiation damage looks like under colonoscopy. So this is a normal colon, the yellow part. This red part is inflamed colon with blood vessels all engorged. So this is a picture of radiation damage. So this can manifest as frequent urgent bowel movements, but it could also cause bleeding. So on the topic of radiation, which Dr. Munt will talk more about, this is one of the newer treatments for radiation, which is the concept of hypofractionated radiation. In the olden days, we do the 8.5 weeks of treatment, where you go in Monday through Friday for 2 months. And it's good data, it's robust, it works well. So now they're pushing the envelope. What about, can one do treatment for 4 months or 4 weeks and be done with it and have the same benefit and side effect profile? And now, some doctors are doing 5 visits over 2 weeks. So this year there was finally some solid, decent follow-up on the 4-week duration of radiation therapy. And so this trial is called the Prostate Fractionated Radiation Trial, ironically known as the PROPHET trial. And for the radiation oncologists, they call it lack of profit because they're treating the patients less often, so they actually get less income. But it's called the PROPHET trial, and this was a very big study where they put about 600 men to do 4 weeks and 600 men to do 8 weeks. The average age was 71. Most patients had intermediate risk cancers, and the PSAs were greater than 5 in most of the men. So low intermediate type, not high risk patients. Okay. And they followed these men over 6 years. And they found that the likelihood of relapse was very similar. So there's no difference in the shorter course versus the longer course. The death rate was very similar. So at 6 years follow-up, they're equivalent. So really there's no reason to need to do a longer course treatment in terms of success rate. And near-term urinary problems around the same. Long-term urinary problems the same. There were more patients with bowel movement problems in the short term, first 3 to 6 months, more diarrhea, more bloody stool, more redness in the colon if you did the colonoscopy. Interestingly, there were a little bit more long-term bowel problems in the traditional old-fashioned 8-week treatment. I think the bowel issues can be minimized now that we have hydrogel, which is something we talked about maybe a couple years ago. It's a little gel that you could inject between the prostate and the colon. So that will protect the colon when you do radiation therapy. So the bowel problem should be less and less as hydrogel gets implemented more and more. So ask your doctor about hydrogel. Yeah. What about focal therapy? Focal therapy is something that we're very interested in. From our perspective, patients are always interested in focal therapy. And why do we need to treat the whole prostate if there's just a little bit of cancer on one side, one corner, front or back? It's like another way of looking at it for breast cancer. We're no longer needing to remove a whole breast. We just do a lumpectomy. So why can't we do that for prostate cancer? And there's a lot of pros and cons to that, but these are some of the purported, popular focal options now. Unfortunately, none of them really have amazing data, and I guess I would say focal cryo would have the most of these. But now they're doing focal seeds and maybe even injecting little Botox into the prostate. So Dr. Bond does that. So it's yeah. So, exactly. So why not do something focal? And so last year and this year, there's a little bit more published stuff going on now. There's the Dr. Walser in Texas. There's Dr. Sperling in New York. They do it, but there really hasn't been much good publications from them. And so I've always been a little bit scared referring. And even at UCLA where they did publish something, let's go over that right now. It's only 10 men. These are mostly intermediate risk patients who should get treatment. It's an outpatient procedure. They use an MRI and an ultrasound. There's no general anesthesia. It's MRI. It's just local nerve block. And it takes about an hour to 2 hours. The average time is about an hour and a half. So time to get a little queasy here. So this is kind of how they do it. This is the laser tip, and these are the probes that determine the temperature. In other words, guide and tell the laser not to go too far. And imagine this is the prostate, and these needles monitor the temperature of the prostate, and this is where the laser goes in, and it tries to treat this green area. Okay. So these are the 10 patients that they've treated so far. Of course, they're mostly Gleason 7 patients. These are their PSA levels, anywhere between 10 and as high as almost 15. The prostates are not too big. The average region of interest diameter, these are not tiny lesions. They could be as high as 20 millimeters, which is almost an inch. Okay. A lot of them are, most of them are Gleason 3s and 4s, but they did have 2 guys with some Gleason 5 component, which is, Gleason 8 or above. Let's see. And, I'm sorry, this is the MRI grade, sorry. So this is the MRI PIRADS grades. And this is a way of grading the cancer on the MRI. These are the locations of the cancer, and these are the maximum length of the core cancer in each core. Okay, so basically the take-home message is intermediate risk cancer. And so what they did was they biopsied all these men, and these are the guys who have negative biopsies in the rest of the prostate. They have positive biopsies in this region, the green area, and the goal was to radiate or laser this region only, and using the probe, the needles, to prevent the laser from going outside the area of interest. So the needles will tell you, where you can have the needles tell you when the laser goes in and you turn it on, this is how high the temperature goes. But you want to keep the temperature low at the other areas, of course. So after the treatment, this is kind of the hole that's left behind after the laser treatment. So these are the 10 patients, and so each patient had a hole in their prostate, basically. Okay, and so it's kind of like a lumpectomy. You just remove the spot where they think the cancer is. So it sounds very logical and simple, and this should be the standard of care, shouldn't it? Probably less. Definitely these men didn't have any urinary complaints. They didn't have any sexual problems afterwards. The average amount of pain, they said, was, it's about a 5 out of 10. That's on the 1 to 10 scale. A lot of the guys had temporary bleeding afterwards, but these are the 10 holes that were left behind. Okay. So, doctors, they're not satisfied with the hole. A hole doesn't mean there's no cancer in there, right? So what they did was they re-biopsied all these men. Okay. So look what happened. 7 of 10 men still had cancer. Yeah. So 3 people had no more cancer. Okay. A lot of these guys had less cancer. The length of the cord was smaller. Okay. A lot of these guys had, some of these Gleason 7s became Gleason 6s. Okay. So is this a win or loss? I guess for these 3 men it's a win. Okay. But for these other guys who still have cancer, you go through a 90-minute procedure, you're still, dealing with it. So why did this happen? Well, the cancers aren't always as sharply demarcated as we think. Cancers may look like this, but they have little tentacles that we don't see. So you could do a laser ball around the tumor, but you can miss those tentacles that expand. Or simply the laser wasn't enough to kill the cancer. So this is interesting, and hopefully we'll get better lasers, better ways to do focal therapy. But this is at least a start. University of Chicago, they had their success rate was 60%. So 2/3 had negative biopsies. Okay, so we'll see. And that was a 20-something study patient. So these are small studies. So when you hear doctors say, "Oh, laser works, let's send me to Texas, send me to New York," well, we're not so sure. Just be prepared. If you objectively look at this and you re-biopsy these patients, there's maybe a 60-70% chance that there's still some cancer there. Okay. So what about high-risk patients? These are the guys who have higher Gleason scores. They have a larger nodule. Their PSA could be a lot higher. More cores are involved. The cancer may have broken through the capsule or invaded into seminal vesicle. Again, these have not metastasized, but all these factors that I just listed, they increase your likelihood of metastases. So if you have any of these, your likelihood of having metastases is probably 40 to 60%. So in other words, if you treat the prostate, there's a 40 to 60% chance you're not done because it's out here already that you don't know about. So these are the guys that you do surgery, but you might need radiation afterwards. You do seed or you do radiation, but it's probably better to combine it. And a lot of these guys will need androgen deprivation. Now, last year we talked about the UCLA experience on the combined treatment. Their experience was the combo is better than surgery or radiation by itself. So that was kind of a retrospective study. So these are kind of the treatments I just mentioned earlier. So for higher risk patients, we also consider abiratirone and chemotherapy. We'll talk about that today. But this is a prospective study of the concept of will seeds plus radiation be better than radiation by itself for high-risk patients? And the answer is yes, based on this 400-patient study. Half of the men received radiation by itself. The other half received both. Everybody had to take a year of androgen deprivation because, again, you could do whatever you want to the prostate, but you're not really addressing the 50% chance there's something out here. But in any event, if you do more to the prostate, meaning the combination, there's going to be a better outcome, and we're going to go over the data right now. This is a 6.5-year follow-up, and they estimated and calculated that the risk of relapse of the combination group, or the likelihood of remaining free of relapse, let's put it that way, in the combination group was higher at every benchmark. Okay, so at 9 years out, there's around a 20% chance more higher that the combination group will remain in remission. Okay, so this is prospective, not a retrospective study. So it's a little more convincing than the study I presented last year. So I think for high-risk patients, treating the mothership with more treatment, meaning a combination, is better than radiation by itself. And remember, you don't want to do the 4-week treatment for high-risk prostate cancer. Okay. So another concept with high-risk prostate cancer, again, is another systemic therapy, which is called Abiratirone. Traditionally, Abiratirone, we use it when ADT stops working, what we call castrate-resistant prostate cancer. But this was a study called the Stampede trial in the United Kingdom, where they looked at 2,000 men, and these are all men who've never received ADT, and they were diagnosed with prostate cancer, and half of these men had metastases, 20% had nodal involvement. But let's just concentrate on the 28% who do not have metastases, in other words, high-risk disease. Okay? They were treated with ADT and abiratirone, and most of this group received radiation therapy. Okay? Again, to cure the patient. Okay? And they found that this is for all patients, and we'll go over this at the later slide. The abiratirone group was much better in terms of all the clinical parameters. But
What's the trade name?
Zytiga. Sorry. But we're going to look at this chart here. These are the guys who do not have metastatic disease. These are the high-risk localized disease patients who underwent radiation for cure. The top line is the blue line is the group that had abiratirone, ADT plus radiation, and the bottom line is the group that had placebo, ADT, and radiation. And the line represents the likelihood of not progressing, the likelihood of remaining in remission. See how different that is? At the 4.5-year mark, there was about a 30% difference in likelihood of remaining remission. So about 60% of the men in this group already relapsed, or 40% of the men in this group relapsed, and about 10% in the other group relapsed. So 40 versus 10%. Okay. So for high-risk patients, Zytiga in this study there's good data behind it. But this is not enough data. This is a larger. This is it. So for high-risk disease, Zytiga should be implemented to improve the cure rate. So let's jump into, you've done your treatment. Unfortunately, you've relapsed. And I saw there were a lot of men who raised their hands when they relapsed in this group. So a little bit about relapse disease. This is the first time we have some data on bicalutamide. But stepping back a little bit, relapsing typically, most commonly it happens after surgery because surgery has been the most common treatment. And usually after surgery, the first sign of relapse is the PSA rising. And usually when that happens, we recommend that the patient undergo radiation therapy. And we just radiate the prostate area and hope that there's, the cancer's within that area. And depending on the patient's PSA, his Gleason score, if he had positive margins or not, the success rate for radiation can be anywhere between 20 and 70%. Usually you want to do radiation if the PSA is less than 1. You want to do it as low as possible, in fact. You wanted patients who benefit the most from radiation to actually have a slow PSA doubling time. But there's never been any data on whether or not adding hormone therapy really changes overall outcomes until this year. So this was a study published about 9 months ago in a New England journal where they randomized 760 men who just had a rising PSA after surgery, and everybody had radiation therapy. Half the men received Casodex, or bicalutamide, for 2 years in conjunction with radiation therapy. The other half received a sugar pill, and they followed these men up for 12 years. Note here that the average PSA was about 0.6. We're dealing with invisible cancer here, and the average age was 65, and they followed these men for 12 years. So the group that had all the data on the first row are men who've had bicalutamide. The other group is placebo. The relapse rate was a lot lower at 12 years. The likelihood of dying from prostate cancer was over 50% less. Okay. The survival was statistically significant, but about 5% difference. Okay, because relapse doesn't necessarily mean death, as you guys know. Okay, the overall number of deaths, not just prostate cancer, was 46 to 21. Okay, but the take-home message was that the prostate cancer death rate was lower. Overall survival was a little bit lower, higher, and there's a 33% decreased chance that you'll be dealing with a rising PSA if you did 2 years of bicalutamide. Okay. So what are the side effects of this treatment? Oh, I did this little thing I forgot to do. and this is survival curves, which basically we explained earlier. So let's talk about side effects. Okay. So this will take a while.
That's not funny.
So that's the main side effect of bicalutamide. So gynecomastia. And gynecomastia is, of course, very distressing, and it's not a good thing. And sometimes it's uncomfortable because it hurts. So it's important, anyone who gets bicalutamide should do either preemptive breast radiation or preemptive medications like Femara. Okay, that will prevent this occurrence. This doesn't happen as much with Lupron, by the way. Okay. So let's talk a little bit about metastatic disease. With metastatic disease, now we're talking about a systemic condition. So most importantly, metastatic disease is where all the systemic therapies come in, and we'll go over some of the newer data from 2017. But we often use ADT, chemotherapy, Abiratirone. Of course, there's enzalutamide, which is Xtandi, radiopharmaceuticals, which is Alpharadin, immunotherapy, which is experimental but should make a mark in the next couple of years. Metastatic disease can manifest as spots in the lymph nodes, spots in the liver, spots in the bones. Okay, so this is metastatic disease. Okay. How do we treat metastatic disease? My famous cartoon. So this is queasy. So this is Lupron here. And this is Dr. Schultz. No, kidding. So this is the traditional way of treating metastatic disease is androgen deprivation therapy. And it prolongs life, minimizes symptoms, but eventually ADT does lose its effect, and it doesn't work forever. And so traditionally we use all these things, multiple things, after ADT stops working. But about 2 years ago, we learned that, and last year we learned that chemotherapy, Taxotere, when you use it in the beginning, before ADT stops working for metastatic disease, if you use it in the beginning, it makes ADT work longer and patients live longer. So going through a 4-month course of chemotherapy in the beginning of metastatic disease prolongs survival. This year, we've learned that you don't have to do chemotherapy. It turns out Abiratirone does the same thing. And we're going to go back to the Stampede trial. This time we're going to talk about the 70% or so of men who have metastatic disease and who had Abiratirone added to their ADT. Okay, and half, 2/3 of the men had, about 700 had ADT plus Abiratirone, 700 had ADT alone. So this data is all comers, but this really represents the metastatic patients the most. The 3-year survival was higher with the combination group. The likelihood of not progressing is 30% higher, okay, if you took the Abiratirone. So over half the men already progressed, meaning Lupron stopped working. Okay. Whereas if you added Abiratirone in the beginning, only 1/4 of the men developed castrate resistance. The absolute numbers were 500 versus 200 men who had treatment failure. And look at here. There were twice as many men who had metastatic, new, painful skeletal metastases. So 50% less likelihood of getting pain in your bones if you took Abiratirone in the beginning. So this is a very powerful study. Large study, good follow-up. And so this, there's been some talk about, well, maybe chemotherapy in the beginning should be used for men who have a lot of metastatic disease. And not for guys who only have a little bit of metastatic disease. Well, this study, Abiratirone helped in men with a little bit and a lot of metastatic disease. So we've definitely incorporated Zytiga, Abiratirone, into our practice. And we have another study, I'm going to skip these charts, another study called the Latitude study, which again supports Abiratirone. So this study had a large group of men, 1,200 men, and half received ADT plus Abiratirone, and the other half received ADT plus placebo. These men had metastatic disease. They either had 2 of the 3 conditions. You could have Gleason 7 and visceral mets, Gleason 7 and skeletal mets, visceral and skeletal mets, at least 2 of these 3 items. Okay? But everyone must have had some sort of metastases. And again, this data was in favor of Abiratirone. the survival rate was 17% higher, 2/3 versus half. Okay. The likelihood of remaining no change in your scans was, duration was about 3 years. A little over a year later, you're going to have new spots if you did ADT by itself. It took almost 3 years before the PSA started rising if you did the combination. And if in this group, gosh, only 7 months later, Lupron stopped working. Okay. The average survival, if you just took ADT, was only 16 months. And they hadn't really, time to pain. The time to pain was 16 months. You started having pain if you took ADT. They couldn't even measure when that the patient started having pain on Abiratirone. There's another column here. Survival was a big difference too. They hadn't even gotten the average survival yet, whereas the ADT alone group was about 3 years. So this study, the Latitude study, came out at the same time as the Stampede study. So we got a lot of reason to use Abiratirone for newly diagnosed metastatic prostate cancer in conjunction with ADT.
Doctor, you need to change this Abiratirone, whatever that is, with chemotherapy if chemo was done because it's early?
We don't know. So we know that chemo plus hormone therapy is better than hormones alone. Abiratirone plus hormones is better than hormones alone. We don't know if Abiratirone plus chemo is best. So in some patients who I really think they're going to relapse soon, I may use both. Some men, we don't do Abiratirone because it's like $100,000 a year and it's 3 years, at least 3 years. Chemo is 4 months, so it really depends on the patient. If he has a lower volume disease, I'd be more inclined to do Abiratirone. Okay. So we don't know if we should combine everything. Okay. We won't know that for a couple years.
Could you remind us again, what is Abiratirone?
It's a pill called, another name is called Zytiga. It's a hormone pill. Think of it that way. Okay. So that's a medication that works hormonally, okay, against prostate cancer. And in the olden days, it's used when Lupron stops working. Okay. Again, these are kind of survival curves, which all benefit Abiratirone. Okay. A little bit about immunotherapy. We touched upon the immunotherapy last year with PD-1 inhibitors. Of course, Provenge is the only FDA-approved immunotherapy. PD-1 inhibition is a treatment, anti-PD-1 treatments is now approved for about 7 cancers now. They're including melanoma, stomach cancer, bladder cancer, kidney cancer, lung cancer, among others, lymphoma. So the way PD-1 inhibition works is this is the T cell, which is the main immunocell that we all have in our body that fights cancer. These cancer cells have this way to inhibit the T cells by binding to the PD-1 receptor on the T cell. So the cancer cells can cause your immune system to be suppressed, in other words. Okay. So the concept is if we can prevent the cancer from suppressing the immune cells, maybe the immune cells will start killing the cancer cells. And it has worked in a number of cancers. So we're hoping that it works with prostate cancer.
Again, is there a trade?
Oh, yeah. So there's a lot of brand names now. There's Keytruda, Opdivo, Tecentriq. So there's like 4 or 5 PD-1 inhibitors. The earlier ones, it turns out that the Opdivo was not really working for prostate cancer. So we've learned that in the phase 1 studies. But Merck went ahead and did some studies with Keytruda, and I presented one of the studies last year, this one. And there were about a small number of men, their cancer shrunk, and a lot of men, their cancer stabilized, and and the average stabilization was about a year. Okay, so we went over this last year. So we started treating patients January 2017 at our office with Keytruda, and we treated 31 men, 27 men with castrate-resistant prostate cancer, 4 men where Lupron was still working, but we thought, let's try Keytruda for this earlier stage type of men. The PSAs weren't that high, so these men were not as sick as this group. PSA was on average only about 8. Okay, and so far, our results are a little bit better. About half the men have had a PSA response, or the PSA just stopped going up. About half the men had disease progression. Now, granted, our follow-up's still very short, so more data is needed. But it's kind of promising that immunotherapy is might be helpful. This was a very interesting study presented at ASCO this year, where they combined immunotherapy. This is another PD-1 inhibitor called Imfinzi, and they combined this with a PARP inhibitor, the BRCA treatment called olaparib. These men are, and these are not BRCA positive patients. These men, 25 men so far that they've started screening, and they treated 10 men so far, 10. And of the 10 men, all these guys are very sick. These PSA levels are 86, way higher than the group that we treated. Average PSA is 86. And the first 7 men that they treated, 5 of these men had a PSA drop, 50%. So that's really exciting, using immunotherapy, plus a PARP inhibitor. In fact, 3 of these men, their PSAs dropped over 80%, or 79, 94, 99%. So I think in the future, combination immunotherapy is going to be what's going to be moving the needle in our field. In the other fields, it looks like single agent works and combo works better. I have a feeling single agent works very so-so in prostate cancer, so we're going to need combination treatments. So these are some of the combination treatments. Opdivo plus ipilimumab, which is Yervoy, Tecentriq plus Xtandi, Tecentriq plus Provenge, we're doing that right now, Keytruda plus olaparib, and then we'll get more data on this Imfinzi plus olaparib. Okay, so combination immunotherapy should be will be a lot more promising. Sure. So, a little bit about alpha-radum, radium-223, or the brand name known as Xofigo. Basically, I call it liquid radiation into the bones. The radiation medicine gets dripped into or injected into the veins. The medicine goes into the bones, within the bones, lands within the cancer, and releases radiation, killing some cancer cells. Doesn't work for lymph node or liver metastases, of course. So it was approved about 4 years ago because it did improve survival. It definitely decreased bone pain. And we even use it in combination with these newer hormone medicines. Okay. This is a new type of liquid radiation called lutetium, which they're just starting a trial at UCLA, but this is some data from Germany, which was released earlier this year. This is liquid radiation again, but it not only goes in the bones, but also soft tissue. Okay. And this is a gentleman with a PSA of 300. He got the liquid radiation lutetium, and 6 months later, his PSA dropped to 9. Let's see here. Or 3 months later, dropped to 9. 5 months later, dropped to 2. And 7 months later, his PSA stayed at 1. He had a couple doses. Okay, it wasn't one dose. Now it's done in Germany, Sydney, Australia, and UCLA will start. Yeah. So this is very exciting. Again, it doesn't work forever. But it should give, if you're fortunate like this guy, you're going to get a nice remission. Okay, you're going to live longer because of this. Some side effects could cause severe anemia, it could lower your blood count because the radiation could kill off some of the good cells. If you get this, you may not be able to get that much chemo later on. And at this point, it's really pricey because it's experimental. Okay. So we'll see. I think we'll need a couple more years for the data to mature and more patients to be, researched on. There might be a gentleman here who got it. If he's here, raise his hand. Ah, there he is. Yes. So he's doing well, I hope. So far, so good, right? Yeah.
Sydney after Thanksgiving.
Yeah. You want to share your experience a little bit, or?
Oh, well, I went to Germany first, and then I was one treatment, and then the treatments were 8 weeks apart, and I learned that the treatment was cheaper in Australia, so the second treatment I was there was $15,000 in Germany, it was $8,000 in Australia. I had no side effects to speak of, maybe a little tired the day after. My PSA after 2 treatments has gone from 230 down to 50, and may still be dropping. I'll find out on Tuesday when I see you.
So yeah, that's great. We have a gentleman with a response. I'm estimating maybe 2 out of 3 men will respond. And maybe they'll respond. I don't know how many will respond like this gentleman here, but you're doing good. So that's exciting. That's exciting. Yep. Okay. So this has always been a controversial topic. We finally have some reputable data. Okay. So they call it bipolar therapy, but basically this is giving testosterone to men with prostate cancer. Okay. And we've always talked about deprivation, castration, removal, hammer, What about giving testosterone? So it turns out that, it's, especially low-risk patients, testosterone is not that dangerous after all. Okay. The concern has always been giving testosterone in men who have active cancer. And there's a little bit of data now that is interesting. Okay, so let's go over that. This just came out this year, or more. This matured this year. This data matured this year. It was first reported by Dr. Schweitzer 2 years ago, and then at the end of last year, the Restore trial came out, and they took 30 men on Lupron and Xtandi, and the cancer was growing. So what they did was they gave testosterone once a month. And in that injection, which usually lasts a week or so, that patient's testosterone went up and then came down. Okay. So the 30 days of the month, the testosterone stayed low, but the first 7 to 10 days, there was a surge in testosterone from this injection. And they did this once a month. Okay.
You mean surge in PSA?
Testosterone. Yes, because of the testosterone shot, okay? But look what happened. 9 of the 30 men, their PSA dropped by 50%. Yeah. So actually, testosterone may have improved things in this castrate-resistant group.
Lyle loves you.
This is for Lyle. It worked for about 8 months. So it didn't work forever. Okay, a lot of guys felt a little more energy for a week or so. Okay, there were some men who had problems. One guy had a heart attack. One guy had blood clots. Okay, one guy he couldn't pee because the cancer grew and caused bladder blockage. Now it could have grown regardless, right? It didn't. We may not have to blame it on the testosterone. 2 guys, their pain immediately went up. So testosterone may feed the cancer, may even improve the cancer. So we're kind of in this. So the key is finding the men who we feel that might benefit without hurting them. But at least the tide is kind of turning a little bit. Okay. So very interesting data. Hopefully we'll get more in the next couple of years. So just want to summarize For low-risk patients, I think active surveillance is becoming the standard, just by seeing the number of men raising their hands. Maybe focal therapy, like laser treatment, is interesting, but we got to take that with a grain of salt. We need a lot more data. Okay. Intermediate risk patients, same thing. Focal therapy is interesting, but take it with a grain of salt. We definitely could do shorter courses of radiation therapy, maybe 4 weeks. Okay. I can't say for sure we have enough data to say, oh, just do the 5-day treatment for 2 weeks. Okay. But I have a feeling that's going to look pretty good as well. High-risk patients, we got really good data now that you really should combine the seeds and the radiation together, and use Zytiga in the beginning. If you relapse, in addition to doing radiation to the prostate area, add 2 years of bicalutamide or Casodex. Okay. If you're metastatic and you never had Lupron before, either add Taxotere or Abiratirone. Okay. Maybe both. Okay. And look for some trials of using testosterone. Okay. Or lutetium. Okay. Immunotherapy, we're still waiting for more data. I think combination immunotherapies are exciting. And hopefully we'll get more data this year on combination immunotherapy, treating immunotherapy and oligometastases. We didn't really talk about oligometastases this year. I think we'll get some data next year on olaparib, which is the PARP inhibitors we use for BRCA patients. Lutetium, we'll get more data. There's a new liquid radiation called actinium. They're studying it now. And definitely we need more data on the focal therapies like laser therapies and HIFU and the shorter course of radiation therapy. This is, just want to do a quick plug of my partner's book. This just came out called The Key to Prostate Cancer. And so he wrote many of the chapters. I wrote one in here. He had multiple doctors contribute chapters into this book. It'll be less, hopefully it'll be a very educational read. Ralph Blum did not. We miss Ralph. He was a really excellent, he contributed a lot to the last book. And just want to thank you guys.
Who was the author?
Mark Schultz, my partner. Yep. So just on that note, I want to thank everyone for having me, and I'm here to answer some questions.
Now you understand why we have Dr. Lamb here and what it means to be a prostate oncologist and cover the whole spectrum. Thank you very much.
Sure.
So let's open it up to questions. We'll start here and then we'll scan down here. The question?
Yes. Dr. Lamb, do you have a comment on prostate cancer treated patients with radiation who are being given TRT, testosterone replacement, not for the purpose of maintaining cancer-free, but treating hypogonadism?
Yeah, so I think testosterone replacement therapy is, if the more confident we are that you're cured, the less fear we have of giving you testosterone. So testosterone definitely improves quality of life. It's kind of like the fountain of youth. Women took estrogen and now women take estrogen sometimes even after they have breast cancer. So men, the equivalent of estrogen for men is testosterone, and I think in select patients, go right ahead. And
yeah, I'm one of them.
Yeah.
And I'm all for it. I mean,
yeah.
I recommend it highly, but it's such a sort of a rare sort of cul-de-sac in the big picture. A lot of urologists don't want to even talk about it.
Yeah. And so it's going to be a slow tide change. I think some ways I tell patients if they're going to relapse, maybe taking testosterone, you'll know the truth sooner. You'll relapse earlier. Now, it's relapse for prostate cancer is not as dire as relapse for lung cancer, pancreatic cancer, any cancer, because prostate cancer, even if you relapse, it's more like a chronic disease. And so relapse doesn't equal death in prostate cancer. So maybe there's less of a downside, And it's a calculated risk, We put people on cardiac treadmill tests and to see if they have heart disease. And occasionally you drop dead of a treadmill test. So the treadmill test is kind of like the testosterone. You're testing if they have heart disease. You're testing if they have prostate cancer. So.
Okay, questions? There. Yes, sir.
Regarding radiation combo treatment, what sequence are they given in, external versus?
It's usually the external sequence of, is it radiation seeds or seeds radiation? Usually radiation seeds. The rare doctor who does seeds and radiation, there's one guy at Georgia. He does it the other way around.
Yes.
What do you think of using DHT for recurrence for biomarker as well as potentially blockade? And I caution that I tried asking this locally again, and it was no. Same issue in San Diego.
So I guess the big question is DHT. Let's just do a little blurb on that. DHT is dihydrotestosterone, and it's made from testosterone. So testosterone is converted to dihydrotestosterone, and DHT tends to feed prostate cancer more than testosterone. So you could decrease DHT by taking finasteride or dutasteride or Avidart or Proscar. And if you lower the DHT, you'll probably slow down your PSA from rising. And I think it has a mild anti-cancer effect. From a practical standpoint, it's probably a good way to delay Lupron. Okay. It's also, if you're on active surveillance, perhaps you might get less surveillance biopsies. You might even prolong your active surveillance. Of course, we can't say DHT changes one's destiny. How long you're going to live. It's a light, easy pill. So maybe that's why some doctors, don't really want to waste time and energy in it. But I think avoiding Lupron's a big deal.
I am Exhibit A for not taking Lupron for 10 years and taking Casodex and Avidart. And it's worked for 10 years. But now I have to take Firmagon, which is a Lupron equivalent. But it worked for me for 10 years. And but it's rarely prescribed here in San Diego.
George, what is the standard dosage of finasteride and Avidart, or either one or both?
Well, the Avidart, it's the standard, and I forget how many milligrams.
So Avidart's 0.5.
Is that once a week?
Daily. Yep. And finasteride's 5 milligrams every day.
Every day?
Yep. And 99% of the time, your DHT levels will be very, very low.
Well, I'm being prescribed 5 milligrams once a week of finasteride. That doesn't seem like...
So the best way to know if that's enough is check the DHT level. Yep.
What I did, because I'm an engineer, I started off at 150 with Casodex and went to 150 and then 25, and that started to rise, and 50 was the rest for the next 10 years. So I experimented. Okay, question here. Yes.
You showed on the slide the HIFU approved 2015. What kind of data do you have to show how successful that being forward?
So HIFU is HIFU, and it's basically high intensity focused ultrasound using the sound waves to dial it up to a high intensity where it could kill cancer cells. Most of the HIFU is used for the whole prostate. So, and it's about 70-80% successful when you treat the whole prostate. Focal is the next frontier. It's about 50-60% successful. There is some wound issues. It's less precise than the laser, so you're going to have a little more risk of urinary problems and incontinence and sexual problems. Not as bad as treating the whole prostate, but it's probably not as precise, which might make it better than laser. You don't want to be too precise and miss the cancer. There's also a phenomenon called fistulas that they've seen with HIFU, which means you start peeing poop and pooping pee. Urine might come out of your anus. So we don't like that, and not crazy. So that's why I'm not crazy about HIFU yet.
Yes.
I hate to be morbid, but my doctor tells me that the people don't normally die from prostate cancer, but from other infections and whatnot. And I'd like to know how people die from prostate cancer.
So, there's, at the end of the day, there's still about 28,000 men who die. As you know, prostate cancer is more of a older gentleman's disease, and older gentlemen have other conditions. And, Alzheimer's is moving up the list, heart disease, strokes, other cancers. But if you die of prostate cancer, it's usually related to the cancer in the bones, and your body just doesn't make enough red blood cells, platelets, white cells to keep surviving. So, and you just become weaker. Sometimes it can affect the kidneys, and so it has multiple ways of affecting you. Sometimes it affects the liver. So, and it's not like a boom, you die. It takes a while, and it's kind of like accelerated aging. You just age really quick.
Okay. Any more over here?
Yes. I'd like to mention, about 10 years ago, I had cryosurgery. Following the cryosurgery, PSA shot up 1 year later. Finasteride, your dose that you mentioned, has been on since. Second cryosurgery a year ago. Really down PSA now with finasteride, increasing percentage-wise enough to warrant going radiation, which I'm halfway through. The finasteride was prescribed after the urologist detected bladder distortion from the prostate. Why the prostate went hyperplasia super following the cryosurgery, I don't know. So I've been on finasteride for 10 years continuing, and I've had 2 cryo operations and now radiation. So I thought I'd like a comment on finasteride as far as any relevance to prostate cancer.
Can you make a question out of that to answer?
So, finasteride officially is used to shrink big prostates. And big prostates make a lot of PSA. So when you do take finasteride and your prostate shrinks, your PSA will drop. So one take-home message is don't necessarily be fooled that a PSA drop is related to cancer shrinking. And so on that note, some patients, their doctors say, oh, your PSA rose from 2 to 3. That's not a big deal. Let's check it next year. But the true PSA, if you're off, and that patient's on finasteride. If that patient wasn't on finasteride, it probably went from 4 to 6. So the finasteride can mute the PSA rise when you don't know if you have cancer, for a regular person who's taking finasteride for a big prostate. So if your PSA rises a little bit on finasteride, it means a little bit more than if your PSA rises a little bit when you're not on finasteride. On a separate note, if you, let's say if you did cryo or surgery and your whole prostate was gone and your PSA was 0, and your PSA started going up, it turns out that finasteride can lower or stop the PSA from going up, and there's no more prostate. Okay, so in that situation, that's a key indicator that finasteride has an anti-cancer effect. Excuse me.
Okay, cool.
Can you tell us more about the mechanism of action for Zytiga and the risks and side effects of it as compared to AD?
Sure. So Zytiga is they call it a CYP inhibitor, but it's basically when we take androgen deprivation or Lupron, we basically tell our testicles to stop making testosterone. And it turns out that there's other sources of testosterone, such as the adrenal glands, and they make a little bit of testosterone, but that's a little bit enough to feed the cancer cells. And so the Zytiga shuts down the production of testosterone from the non-testicle organs. I think it shuts down even a little bit more the testicles. Okay, and it also turns out these cancer cells are very tricky. They can make their own testosterone. So Zytiga will shut down the testosterone made from cancer cells. So Zytiga they come in a pill form, and you got to take it on an empty stomach. And side effects, leg swelling, hypertension, could affect the liver, could affect the electrolytes, more hot flashes. So those are the common side effects. Okay.
Will it be going generic anytime soon?
I think in about 2-3 years. Yeah.
More questions? Okay, Steve.
Yeah, on Zytiga again. I was a little confused. You mentioned something about you have to be on for 3 years. And is there any percentage of actual total remission with Zytiga?
So a lot of these studies, when you have metastatic disease, you go on Lupron until Lupron stops working, but you stay on Lupron. A lot of these men who took Zytiga, the goal was to keep things quiet, knowing that eventually things will start growing again. But it turned out that a lot of these men took Zytiga for 3 years and still things were quiet. So they just stayed on it. Can we say that? I don't think at this point they have any real data to say, let's stop Zytiga and Lupron and see if the patient remains cured for 5-10 years. Yeah. So for systemic disease, it's going to be hard. Okay. There is some oligometastatic disease data that if you have 1 or 2 mets, you take chemo or hormones, maybe Zytiga, zap that spot, you might be cured. Okay. That's probably, I'm guessing maybe 5 to 10%.
Yes.
Dr. My name is Michael. I've got recurring radiation from about 5 years ago, and I'm in the evaluation stage right now. I've done all the analysis of all the different potential treatments that are out there. There's one called the nanoknife, which is basically you're zapping it with electricity. First question is your opinion on that. Second is I've heard discussion about the immune system when the cancer cells are getting zapped or killed or whatever, and there are fragments of that cancer. Your immune system recognizes that and then in essence teaches itself to go attack regular cancer, prostate cancer cells. So it's kind of a 2-part question. Nanoknife and the immune system attacking the dead and live cancer cells.
So nanoknife is just another way of directing some treatment to a spot. And very early data now, so I don't have much positive or negative to say about that. The concept of priming the immune system by releasing some dead cancer antigens into the bloodstream. I think that's. I think there is some science and there's going to be there's going to be some benefit to that, and we're actually doing some of that with our patients with oligomets. Yeah.
Yes.
I participated in a clinical study for Prostate. What can you tell us about
Prostate?
Yes. What can you tell us about the status of the approval of Prostate?
So Prostate is made by Bavarian Pharmaceuticals. The short answer is it's a vaccine trial, and it didn't pan out. It failed. It was really promising in phase 2, and then in phase 3 trials, Prostate did not meet its endpoint. And that result was released in October last month.
I guess I'm the exception. It worked for me.
Yeah, there weren't enough success stories to move the needle with the two groups. So I don't think I don't know how what they're going to do from now. You know, are they going to do a different type of trial or select different patients?
Yes.
I tried Zytiga and didn't work, and extended didn't work for me. And they prescribed chemo, and I got a second opinion, and the second opinion says it's better for my immune system if I go with radiation. That's what I'm going to do. Is that logical?
So, I mean, everyone's different. You know, the chemo is a little harder. What type of radiation? Just zapping a spot or the liquid radiation? To where? Huh? Where are they going to the prostate? I see it. Okay. I mean, if you don't have that much cancer, you know, and you could address it with some radiation, I think that's a good approach.
One thing further, none of your charts have patients that are as old as I am, and they're 80, mid-80s. I know that they're all in 70s or younger.
Oh, no, the studies were actually the median age. So there were guys younger and older than 70. Yeah.
Okay, yes, sir.
Part of being in this group is that people come to you and ask advice like, we know what we're doing, which, as you know, we don't. But we do know enough things to move people into finding the right answer. A very close friend, I'm trying to save him from his urologist knife. 10 years after radiation, reoccurring prostate cancer, C11 shows the tumor in the location of the previous prostate. You can't radiate where radiation has been done. A, that's the question. And B, how do I talk him out of not letting the urologist cut everything out? Give me some options to tell him besides before I get him up to Marina del Rey.
So this is what you did, Mike. You kidnapped him.
You're bigger than I am.
Yeah, generally you shouldn't re-radiate the same area. Things could really necrose. Yeah. Yeah, I don't know. Can't tell you that one. Yeah.
Okay, questions over here. Yes.
Thalidomide versus Zytiga. You didn't mention, like Zytiga, you normally have to prescribe prednisone with Abiratirone.
Right.
Right. So we don't quite have the same data yet from enzalutamide. Would you prescribe right now enzalutamide instead of Abiratirone based upon current data?
For the hormone sensitive?
Hormone, let's say refractory.
Yeah, hormone refractory patients, you don't have to prescribe Abiratirone. Yeah.
And the similar patients, let's say as a stampede study was done.
Those are hormone sensitive patients. I would still have to do Abiratirone. Enzalutamide data should come out next year. So when that comes out, then we have another option.
We should wait until that data comes out.
Yeah. Now, the prednisone is over-feared. Unless you have bad diabetes, prednisone is not that bad. And we start with 10, but sometimes we just use 5 milligrams. So 5 milligrams of prednisone is not that bad.
Question in the back.
You use the term seeds for brachytherapy. I had high-dose brachytherapy at UCLA from Dr. Camarabo. Would the data translate for low-dose seeds versus high-dose radiation?
I think it does. Yeah.
Any other questions over here? All right, let's switch over to here.
Hi, doctor. I'm glad you're my doctor. I'm on the bicalutamide now, 150 per day. What is the future of that? Is it going to be a reduction, I hope, of the time or the dosage, or is it that's the optimum dosage today?
Yeah, I mean, the question is, can we fool around with the dose? Yes. I mean, there's no one's compared 50 versus 100 versus 150. You know, all the data is based on 150 going back 20 years. Yeah, I think it's based on pharmacokinetics and cancer kill in a petri dish. You know, they came up with 150. There's always a little concern that, you know, just like if you take antibiotics, you know, take the full course. You know, or you know, don't go half-assed because you might create a superbug. And you know, will using, and another thing is some people always say, oh, you know, Lupron's going to work 10 years. I'll do 10 years of Casodex, and when Casodex stops working, I'll do 10 years of Lupron. It's not as easy as that. It turns out that the Casodex takes away from the years of Lupron benefit. So when you use 10 years of Casodex, by the time you use Lupron, it could be 1 to 3 years success. So then the question is, will 50 milligrams, and then you gradually go up, is there a chance that you're gradually selecting a more aggressive bug that suddenly explodes? You know, there's a little bit of a risk there.
Okay. Yes, sir.
Costs for just a second. I heard you say $100,000 a year for Zytiga, and for people who can't possibly afford that kind of value, what are their options?
So definitely try to get Plan D. If you have Medicare, get Plan D.
Could you repeat the question?
How to combat the costs of Zytiga. So if you have Medicare and you get a Plan D drug plan, you know, your outlay after insurance coverage is anywhere between $10,000 and $20,000, which is still a lot of money. And then there are ways to get some grants, and there are ways to get some financial assistance. Another way the British people do it is, it turns out that if you take the Zytiga, maybe half the dose, but you take it with food, more of it gets absorbed into the body. So you could maybe take, hypothetically, less Zytiga, save less money, save 50%, and still get the benefit.
Okay, Steve, you have some financial experience. You want to share that?
I'm Zytiga, and I was just checking the costs on this under Medicare Part D, and no plan will save you from the donut hole on Medicare, but you'll end up paying about $400 a month, $450, and plus you pay one time $2,500 to get you through the donut hole. Next year it's going up to about $3,500. But that's and the cost that they rated on the Medicare formulary is about $9,000 a month.
Thank you.
My experience is that the first treatment, the first month, would cost me $5,000. And thereafter, it would be maybe $1,000 a month after that. So it's a lot depends upon the insurance and so forth. I'm waiting until after Christmas so I can afford it in January.
But if you don't have insurance, you can get on there. Johnson & Johnson has a plan where you can submit an application and they'll give you it for free.
Yes, if you qualify, you have to submit your federal income tax return and things like that. Okay, question in the back.
One more on the financial aspect. You were mentioning previously that ADT plus Taxotere showed some good benefits, as well as ADT plus the Zytiga. Is Taxotere similarly as expensive as Zytiga?
No, Taxotere is 6 one-hour infusions at the doctor's office. So actually, the treatment's covered by Medicare. So that does play a role in choosing doing Zytiga or Taxotere.
All right, question here.
I had prostatectomy for cancer 8 years ago, and now I'm undergoing salvage radiotherapy. Is there, the breast cancer patients often get both radiation and chemotherapy after lumpectomy for microscopic mets. Is there any role of using whatever medication, oral or systemic medication, for the possibility of microscopic mets that are not image? There's no way to image it, but is there any role of doing anything preventative-wise at an early stage?
So radiation after surgery?
No. I had surgery. 8 years later, I had a recurrence.
Right.
So I'm undergoing salvage radiotherapy now.
Okay.
My question is, you're the expert on
So
medication.
there's a slide there, bicalutamide.
At the same time or after?
During and after.
During the radiotherapy?
Yeah, which is what, 6-7 weeks?
Yeah, about 7 8
Yeah.
weeks.
Yeah, start it and then stay on it afterwards for 2 years.
And what are the percentages? How does it improve?
A big 20% decrease in relapse.
Relapse or metastases to bones or distant mets?
Well, relapse would be the first thing that happens. So, yeah. So, 60 versus 40%.
You do it.
That's the benefit. 60% no relapse.
What's the drug again?
Bicalutamide. Yeah. So it'll be in the talk, and it's in this. There's like 4 slides on it. Casodex. Yeah.
Okay. Question there.
When do you use genetic testing, and how often do patients receive useful information from the genetic testing?
So there's many ways to do genetic testing. One is I often use it on the biopsy specimen in the beginning when one is diagnosed. That will kind of reassure me or change my outlook on the type of cancer we're dealing with. So there's good genes and bad genes. So the pattern of gene expression of the cancer can be looked at under the biopsy, in the biopsy sample. The other time we use genetic testing is relapsed or metastatic disease, more so metastatic disease. And some cancers with certain genetic patterns might have, open up new treatments that we never even thought about. So one thing being, of course, the BRCA mutated cancers. You could use olaparib, a drug we use for ovarian cancer.
We got time for 2 more questions. One over here, yes.
When for recurrent prostate tumor, when it comes time to start ADT, would it be better to do the Lupron first and save the Zytiga for later, or are we moving towards doing both at the same time?
Good question. So if you relapse with no metastases, I would not do Zytiga. Yeah.
Okay, question there, yes.
My question concerns testosterone and its absence. This may be a myth, but because I've been a workout places, it seems that all the weightlifters are taking testosterone. And so then I was jarred recently by a press announcement that a study showed that there was an 80% rise of heart failure or AFib from the treatments that either blocked or took away the testosterone. So is that a valid research, or is that it was very recent, like within the last couple of months?
Yep. So the main question is, does Lupron increase risk of cardiac disease, cardiac problems? There's a lot of studies. Some say yes, some say no, it turns out. And so depending on which one you read, I have a feeling it probably increases your risk of heart attacks. The reason is a lot of people who take Lupron, their cholesterol goes up, they gain weight, they get diabetes. So you got to have a good internist or good oncologist fine-tuning things to take care of that. And also, anyone on Lupron, we put them on a vigorous diet and weightlifting regimen. And so I think the healthy living and maybe using metformin and cholesterol pills, that pretty much mitigates whatever cardiac risks. They did also see that people with low testosterone tend to have a little bit more heart rhythm issues, but that's a very small percent. It's like 0.5 versus 1%, so that's a 100% increase in heart rhythm problems, right? But the absolute number is still pretty low.
I'd like to comment on that. I'm Exhibit A for having trouble with Lupron. I got a 3-month shot for my first event, and I immediately got AFib and all kinds of heart problems as a result, but it was a 3-month shot, and so it continued on, and then I got off of it. And then I switched to Casodex and Abidart for 10 years, and that worked. Now that's no longer working, and now I'm shifted to Firmagon, which is a monthly shot, a little more painful, but it is 50% less of the heart effects that Lupron has. So that's working for me. That's just my experience. I'd like to make a comment for those folks on active surveillance. You saw some numbers that shows mortality higher, and you show some other indicators higher than the other treatments. I've studied that in detail, and there's a footnote to it, really, that there were 3 men in that program for active surveillance that probably should not have been. They had a much higher PSA and a higher Gleason and so forth. That wouldn't be the standard today, and that led to that. What is not commented on is that if you're on active surveillance, you don't have those side effects that you get from surgery and radiation. It's side effect less. So don't be discouraged if you're on active surveillance. Stick to it, and it'll work for you if you're under medical care. Now, I don't know if you've driven up to Marina del Rey lately to see these wonderful doctors up there. There's an option for you to consider, and that's phone calls or FaceTime using your computer. Call the office and find out what that would cost you and how much time and all that. It's an option for you if you care not to drive up on Highway 5 and 405, etc. Now, let's thank the doctor for a wonderful presentation.